Okay, welcome to Deuk Spine Institute. We are getting ready to do our second procedure today. I'm going to give you some numbing medicine. Lay still. Our patient is here because she has two bad discs, injured discs, L4-5, L5-S1, both sides. She's having back pain from those discs. They are herniated, bulging, protruding, extruding, annular tear, degenerating discs. She's having back pain. She's having leg symptoms, pains going into her legs, symptoms in her legs. So we got a back and a leg situation. And she's failed conservative treatment. She has a problem that we can fix with a laser surgery. So we're going to go in there and try to get it fixed for her. She's a healthy young lady. Otherwise, likes to be active and do stuff. So we're going to keep her active. We want to keep her healthy and enjoying life. You're going to feel a little poke. That's just me getting where I need to go, okay? You're doing great. Lay still, and we're going to put you to sleep as soon as I can. Why do disc injuries cause back pain? Henry, let's show our audience why do disc injuries cause back pain. Your back? Perfect. That's one of your bad discs, Sean. AP. Still in your back? Interesting. You're doing great. Just lay still. We're going to have you asleep in about 5 minutes. Is that it? Interesting. Shot. I'm right against the facet. Strange. Just lay still. You're doing really good. We're almost done with your left side. Let me know if you're having any pain, okay? Move your hand. All right. Now, are you back, Henry?
Yep, we're back.
Excellent. So let's show the audience why is it that people do get so much back pain from a herniated disc. Shot? Okay, welcome back. You can see how herniated disc cause so much symptoms by inflammation. She's doing really good. We've already gotten into the L4-S1. Where do you feel that? Back? Shot?
Leg,
Which leg?
right leg,
How far down?
all the way.
Okay, you're fine. Everything's fine.
Okay, hold on.
Yeah, we're working around your disc right now, so that does happen. Don't freak out. You're doing good. All right, so I'm going to adjust. She's got a little bit of facet arthropathy here, and she has a lot of swelling in this area. Shot? She's got a very narrow little space to work through. Shot? Any pain? Huh?
Pain in your leg?
Where?
Where is it? Tell us.
Where?
Is it in your back or your leg? Leg.
Is it the same or is it better?
Better than those.
But you don't feel anything new. Shot? All right, there we go. Where do you feel it?
What do you feel like?
In your back?
Felt a shock down where? Shock down our leg.
Give me an AP. We're so far below the nerve root. Let's just see if could be that your spine is pushing us too close to the nerve. I mean, we're nowhere near the nerve. I don't know if she's just tightening up, feeling it? Huh?
Nerve, she's saying it was nerve. She said electric shocks.
Yeah, but there's two reasons. It could be you tightening up and pinching your foramen, or it could be me being too close with the needle. I'm trying to figure out which one it is. Huh? What'd she say?
When I feel you go forward into the disc, she feels
Yeah, right. She's feeling disc pain, which is then causing her to tighten up, which is then causing the nerve. We're just going to give it a second, let things settle down. But I think you're tightening up your back when you feel the disc pain, and that's causing you to pinch down. Is it better now?
couple nice slow deep breaths,
Yeah.
in and out, just relax the
I mean, we're in perfect position, according to the x-ray. I feel very good. I know this is a bad area. You got lots of inflammation and pain down here, and we're moving around that inflamed area. Let's try and just see how things go, okay? Take 3 deep breaths for me.
In and out for us, 3 of them.
1. Good. Take your time. All right. So we've already made the incision on the left. We've got our 2 needles in great position. Is that better? Where do you feel it?
Down the leg. You feel electric
How
shocks
far down?
to the thigh.
Oh, that's facet. That's facet referred because we're so far below the exiting root and we're lateral to the traversing root. Any better? That's my hand on your back, by the way. That's not anything else but my hand. We're working in a very narrow space, so I'm just trying to... Where do you feel that? In your back? Yeah, see, it's really tight.
You feel that into the buttock?
Yeah, that's normal. That's your facet. Give me an AP. You're doing great. Everything is fine. This is the hardest part of the surgery right here. To me, it looks amazing on the x-ray. Everything looks good. We're going to put you to sleep in just a minute, okay? Now, how long have you had your lower back pain for? 7 years?
7 years.
Anything?
Are you doing okay?
Your back?
In the back.
We are at her desk. Huh? What?
It's resolving?
Oh.
Dull ache.
That's perfect. You're doing great. Let me know if it's uncomfortable for you, okay? Just take a few deep breaths again. We're almost done.
You're doing really well.
Yeah, we've only got one more disc to access. The L4-5 on the right. We've already got the other 3 done. So you're doing great. Num num.
Wasn't too bad, right?
Well,
I always say it's easier
Shot?
to go to the dentist.
that's it right there. So I'm giving her some numbing medicine in her fascia and muscle to, reduce the amount of discomfort she's going to have. She is awake. We need our patients awake for lumbar and thoracics in the beginning shot until we are into the target and we have a safe trajectory. Shot. I can feel her facet. You can see the facet joint is enlarged. Shot. Your facets are a bit abnormal, but that's all right. Nothing to get too bent out of shape about. Shot. Mm-hmm. Where do you feel that? Back? Yeah, that's your herniation at L4-5, by the way, in case you were wondering. You're doing great. We're pretty much done placing needles. Next step is verify your discs are the cause of your back pain. Now, when I asked her, where is your pain in the clinic and on our telemed, this is where she's having her pain. It emanates in this area, and what we know from her MRI are there are 2 damaged discs, L5-S1, L4-5. She's had, did you have back pain before 7 years, or it really got bad the last 7 years? When was the first time you ever had back pain that you noticed? 7 years ago? All right, so healthy lady, no problems with her back until 7 years ago, and she's been suffering with back pain now for 7 years, getting worse. It's starting to affect her legs. She has pinched nerves, and she's got symptoms going into her legs. Are you comfortable? All right, we're going to put you to sleep in just a few minutes.
Stay still.
How bad is that on a scale of 1 to 10? What's the highest?
9.
10? Said 10 at the end. Is that where you get back pain? So we found one of your bad discs. That was the L5-S1, by the way. Better now? How bad is that on a scale of 1 to 10? How high does it go? 8? All right. Is that where you get back pain? You get to go to sleep. When you wake up, we'll be done with your surgery. I want you to count from 1 to 100 out loud for me in English. Count from 1 to 100. I guess we should have done 5-1 first, huh?
Oh, of course.
Go ahead.
What do you want?
5-1. Wait, well, no, you want to do 4-5? All right, let's do 4-5. Yeah. Okay, so L4-5 was 8 out of 10 concordant. L5-S1 was 10 out of 10 concordant. Okay. So at this point, we know that these 2 discs are indeed the cause of her back pain that she's had. She told me that. That's why we call it concordant, and that's one of the reasons we have our patients awake. Henry, what videos have we shown?
We showed both.
All right, great. Any questions from our audience?
No current questions.
Now, she is from Indiana.
She's both a nurse practitioner.
Yeah, we're not going to talk about that. She is a healthcare provider from Indiana. That's all I'm going to say. She knows the back quite well, and like most people, she didn't want to have any surgery done. Nobody wants surgery. But you get to a point in life where you realize your whole life is controlled by your back pain. And in her case, pain down in her legs from pinched nerves. So you got to do something about it. The truth is, there's really a lot of surgical options. They include laminectomies, discectomies, implants of metal, plastic, PEEK. There's basically almost 100 different possible treatments, but of those 100 treatments, there's a best one, and this is the very best of all those treatments. In my opinion, the second best for her would be a laminectomy, foraminotomy, and fusion, L4-5, L5-S1. She did not want a fusion. I don't blame her. Fusions are very invasive and cause complications in many patients. So she's a healthcare provider. She's seen those complications. She didn't want a complication. Shot? All right. As I said earlier, there's a lot of swelling down here, not normal. It's not normal to have swelling in your disc or your facet joint, but people that have inflammation in their disc or inflammation in their facet joint get swelling. And she's definitely got inflammation. And that's where her pain's coming from. And you can see it's actually pushing the tube out right there. Do you see that? So basically, we're trying to put the tube in, and the amount of swelling in this L4-5 disc is literally pushing the tube out. Very good. Now it's good. So we have just passed through the tear where the herniation came out in the back of the disc. We literally put the tube in, we've shoved the herniation back into the disc, and we're going to remove the pieces of herniation from inside the disc and the annular tear. We use a laser to do that. There's no tool in the world that's as good as a laser. The laser is by far the best. And we have a laser, thank God. You can actually see the inflammatory tissue right there. It's pink. It's a pink color, and it's not really pink as some of the inflammatory tissue we've seen. Everybody's different. The location of the inflammatory tissue is the same in every patient, and the location of the tear is pretty much the same, the herniation the same. However, what's different is the amount of scar tissue, the amount of calcium, the amount of inflammatory tissue, the distribution in terms of the microdistribution, the amount of herniation. All those things vary a little bit from patient to patient, but we are prepared for those variations with our tools and with our technique. So we can accommodate the various anatomical abnormalities that are seen here in the disc associated with an annular tear that's painful and herniation. The laser is a 1 millimeter fiber, the glass part 1 millimeter across. Which laser is this?
The machine?
Yeah,
The machine, I think this is
the new?
no, because he's working on that. We probably for the next step we can
That's fine. Just curious. Luis and I are just talking about, there's two things. There's the laser fiber and there's the laser machine. Both of them are FDA approved, 100%. Everything we do in this surgery is FDA approved. We've never done anything with non-FDA approved. In the United States, when it comes to doing surgery or treatment of patients, it'd be very unusual to use anything that's not FDA approved. So these fibers are FDA approved, the laser's FDA approved. By the way, the lasers and the fibers are used in other applications besides spine surgery. These fibers are approved and the laser's approved for urology surgery, where urologists go in and blast kidney stones, where they remove prostate tumors, OBGYN procedures where you're removing like lesions in the uterus. So there's a lot of different applications for this technology. It's not just spine surgery. These same lasers are used in the hospitals every day that perform urology procedures, gynecology procedures. What else, Luis? Orthopedic procedures?
Yes.
They're used for like meniscus repairs, shoulders. There's a whole litany of different things that, also brain surgery. We're now using lasers to go into the brain and destroy tumors, remove tumors, as well as what are called epileptic foci, which are lesions in the brain that causes seizures. So lasers are used quite often in medicine. We used to use them for young kids that had spina bifida, where their nerves were not functioning properly in their legs. They were having horrible pain from spasticity. And we would go in and do a dorsal rhizotomy with a laser. It's a very precise tool. That was at Shands Hospital when I did my neurosurgery training.
What percentage of epileptic foci are trauma versus like a genetic location?
So Dr. Berndes asked me what percentage of epileptic foci in the brain are related to or acquired versus something you inherit, right? Well, we don't really know, first of all, entirely, but the most common lesions that cause tumors are metastases to the brain or primary brain tumors. So they would not be genetic, or maybe they would be genetic. Some would consider those genetic. A lot of tumor-related seizures, yeah. And then you have mesial temporal sclerosis, which is the most common cause of temporal lobe seizures, which lots of people hear about, where you have the aura, you know, you have like this sensation, huh? No. No, they can present as petit mal or grand mal, basically whether they generalize and you become unconscious or not. And those are due to mesial temporal sclerosis. Nobody knows why. Nobody knows why patients get scarring of their mesial temporal lobes, at least not when I was doing my NIH work in the Department of Neurosurgery with Dr. Roper, who's now retiring. He was the head of epilepsy surgery. He was my mentor with epilepsy and a lot of the brain stuff I did when I was on my NIH 2 years of research. Anyway, another is called cortical dysplasia. That's where basically it's a developmental abnormality where we don't know why, but the neurons, the inner neurons don't migrate properly and the excitatory neurons don't migrate properly out to the cortex from the germinal matrix, which surrounds the ventricles during embryological development. So there's a variety of different causes of seizures, but I think the most common is acquired through tumors. That's the most common reason people get seizures. Now, in the absence of metastatic tumors or primary brain tumors, other causes of seizure includes these mesial temporal sclerosis or these foci, these lesions in the brain. Is there a genetic basis to them? Probably somehow, you know? Probably. So I couldn't really answer your question, what percentage, because I really don't know. Nobody knows. Nobody's ever been able to figure that out. Any questions on this surgery from our audience?
Yes, this question comes from, I believe it's a Chinese letter that I just can't pronounce at this moment, but it comes from YouTube, and they asked, can a laser be used to treat full thickness annular tears with central extrusions?
Yes. Yes, a laser can. But it's not just a laser. You need more than a laser. You need a technique, and you need a surgeon, and you need a team. So you need more than just a laser. It also depends on what disc we're talking about, what level. Depends on the patient's individual anatomy. But let's just put it to you this way. I've been doing this annular debridement, fixing annular tears. I was the first to do it in the world. We're the first to publish it and describe it. And we're really the only ones currently doing it in 2024. Unless other people have learned my technique and are starting to do it. That said, we have more experience than anybody in the world at repairing annular tears at Deuk Spine, and specifically I do in 2024. I have never met a annular tear that I could not get rid of the pain and symptoms from. There's been a couple of cases where I couldn't get into the disc because of the anatomy of the patient, but whenever I get there and do the repair, it doesn't matter if it's central, paracentral, lateral, foraminal, extraforaminal. If I can get to the disc, I can get rid of the patient's symptoms. So what a lot of people don't understand in spine is they think they understand the spine, but they really don't. And it's unfortunate there's so much misinformation out there. But our goal is not to get rid of your annular tear. Our goal is to clean it so it can heal and not be painful. Our goal is to get rid of your pain that comes from the disc. Our goal is to get rid of your back pain that comes from the disc, to get rid of your leg symptoms that come from the disc. That's it. There's really no other symptoms besides back pain and leg symptoms. And when I say leg symptoms, I mean numbness, tingling, weakness, or pain. Those are the 4 leg symptoms that the disc can cause. Numbness, tingling, weakness, pain. Okay? There's 2 types of pain. There's neurogenic claudication, and there's sciatic pain, which is a shooting pain down your leg. Okay? And everybody's different. Some people have sciatic, some people have neurogenic claudication, which is more of an aching, cramping. With standing and walking, gets better with sitting. Point is, the goal of spine surgery is not to make your annulus tear look normal. The goal of spine surgery is to get rid of your symptoms coming from that disc injury. Turns out that 87% of chronic back pain, like this patient's chronic back pain, 87% comes from the disc, an injured disc, or 2 or 3. As a matter of fact, the average is 2.2 discs per patient with back pain. Wow, look at that. Inflammatory tissue. Incredible. That's pretty good inflammatory tissue. There's a lot of scar tissue here. You can see how thick and chunky this is. The golden color is calcium. That only comes about from years of inflammation going on. Not months, not days, not weeks, years. So this disc, which is the L4-5, Luis? L4-5 left side, this tear and disc herniation, left L4-5, has a lot of scar tissue, meaning that it's been a problem for her for many years. And that's how you get all the scar tissue here. That's how you get the calcium, the golden color stuff. Okay? So, great question. Keep them coming.
We have another question. This comes from Samir on YouTube,
Hello, Samir.
asking, what approach do you take when you can't enter into the disc intraforaminal approach?
Yeah, great question, Samir. So there's been probably 1 in 100 patients, 1 out of every 100 that I cannot get into the disc transforaminal at L4-S1. I've never not been able to get into other discs, just L4-S1. And it's 1 in 100. What do we do? Well, believe it or not, when I wake the patient up and I see them the next day, they don't have any symptoms from L4-S1 when I can't get in. It's the craziest thing. So typically, if you think about it, why can't I get in? It's because they have bad arthritis of the facet joint, or they have a high pelvis, and it basically restricts movement of the L4-S1. Well, that arthritis of the facet joint or the high pelvis that's restricting L5-S1 movement is probably why it's stabilizing that joint for the patient. And that's why the patients rarely have pain on the L5-S1 that I can't get into. But to answer your question, if I had to do surgery at that point, I would do an L5-S1 laminectomy, foraminotomy, and fusion. So I would do, if you know anything about spine surgery, I would do a posterior transforaminal lumbar interbody fusion with Smith-Peterson pedicle subtraction osteotomies, interbody cage, interbody fusion, posterolateral fusion, and segmental pedicle screw fixation on both sides. That's what I would do. That's the most reliable, best second alternative surgery for treating these kind of problems. Painful discs with stenosis and leg symptoms. That's what I used to do for years before I did the laser surgeries. As a matter of fact, if you go to our YouTube channel and you look up Deuk Spine Institute, look up TLIF, T-L-I-F, lumbar fusions, you'll see we have hundreds of videos of my surgeries that I did here, and I broadcasted them from beginning to end. So you can watch me do those surgeries. I've even gone and published in PubMed. So if you go to PubMed, the National Library of Medicine in the United States, you'll find my publication on fusions. I have some of the best fusion results in the world. As a matter of fact, there's nobody that has better lumbar spinal fusion results than me, and I've published them. Peer-reviewed and published. So if I have some of the best fusion results in the world for the lower back, and I do this surgery, which is not fusion, all the time, there's a reason, because this surgery is so much better than fusion. All right, you can see the herniated disc, the blue stuff. You can see the scar tissue right here, the white stuff. And you can see the calcium, the gold stuff, that comes from chronic inflammation. Just about done. Again, this is L4-5, correct, Luis? A lot of herniation here in her back. But she's going to heal up beautifully. Once I get rid of this stuff, the disc will actually heal. It'll take 1 year to fully heal this disc. And the patients have to take it easy for a year. They got to just take it easy. They can't do any aggressive sports, no full contact sports, no wrestling, grappling, gymnastics, football, no competitive sports for 1 year. Typically, depends on the sport. But that will allow this annulus to close and seal. I cannot make the annulus seal. It's not possible. There's no doctor that can. There's lots of gimmicks on the market like disc seal or per-close or annular close. None of them really work. They don't close the annulus. Okay? They tell you they do, but they don't. They're gimmicks. And I'm not a gimmick guy. I don't do things that are gimmicks. So I'm not going to promote something that I know won't work. All right, there should be another needle, right, from the other side down here somewhere. Right, Luis? Yeah. We're going to find it in a second if we keep looking. But my goal is not to look and find it. It's to finish the job and move on. Just about done. We're at the end of the disc right here. You can see the back of it. Some scar tissue here. A little bit of herniation right there. We're just about finished. This is going to be your left L4-5. So far, going very well for the patient. And I'm going to show you when I'm done that the hole in the annulus is small. It's going to be around 3 to 4 millimeters. Typically, it's around 3 millimeters. And the reason is that we've cleaned out the herniation from the tear, from the hole, so now the hole can close. The reason the annulus has not been able to heal is because the disc herniation has been sitting in it, holding it open. It's kind of like you want to close your front door, but your neighbor comes over and they just stand in front of your door and you can't close it until they leave. So my job is to get the herniation to leave so that this disc will heal itself. See, right here is what's keeping it open. I got about 1 minute left on this disc, and we're moving on to L4-S1 left side. Jordan, you ready? All right, well, for those of you who follow us regularly, we got a bit of a late start with the broadcast because our first patient, he was a cervical Deuk laser disc repair, actually refused broadcasting. He didn't want everyone watching his surgery, and of course, if the patients don't allow us to broadcast, we don't broadcast. Even though we don't tell you who they are, we still respect their wishes. Oh, it's not often that our patients refuse broadcasting, but it does happen from time to time. And our first surgery was a refuser to broadcast, which is fine. We don't hold anything against them for that. But he's doing fine. He's probably already gone if I...
He has left.
Yeah, he's already gone. Alrighty then.
We do have a few more questions.
Give me a second and I'll take those questions. I
Yep.
just want to finish this up right here.
Of
This
course.
is... Huh?
No, I was saying, of course.
I can't get... Alright, yeah, there we go. I'm going to show you guys the nerve root in just a second. And everybody wants to know, where's the nerve? Well, we're right next to the nerve. Sometimes patients will have some feeling down their leg as we're getting everything situated. It's not because we're damaging their nerve, it's because we're literally next to it. And you can't do disc surgery, you can't do foramen surgery, basically you can't do spine surgery without being near the nerves. The nerves come out of the spine. So no matter what spine surgery you do, you're going to be working near the nerves. Just about done, 10 seconds. That looks good. All right, so there's your annular defect. Now remember, the inside of this tube is 5.5 millimeters. So the fiber is 1 millimeter. So we got 1, 2, 3, 3.5 to 4 millimeters is the tear at this point. And you can see where the herniation was. It's gone. There's a little vein right there. And the nerve should be right up in that fat there, which we can't see it, but it's up there. So it's looking good. That tear will seal off over the next 12 months. Her body will heal it. She wasn't able to heal it before because the herniation was stuck in there. Kind of like your neighbor being stuck in your front door when you don't want them there. You want to close the door, but they're not moving. So you need somebody to come by and move them out of the way. And that's what we're doing. This is the most successful surgery in the world for back pain. We've done an analysis of patients for the last 3 years. We have 500 patients that came to us with chronic back pain. It turns out 87% have disc pain, pain from a disc. Turns out that the average patient has 2.2 discs that are hurting them. And when we do the laser surgery, look at that. Oh, you did that? Nice job. When we do the laser surgery, can you pull my mask up above my nose just a little bit? Starting to creep down. There we go. When we do the laser surgery, we get rid of 99.6% of the patient's preoperative pain that was in their disc. Discogenic pain, we call it. Pain from the disc that we're operating on. 99.6. There's no surgery in the world that gives you 99.6 pain relief, 99.6%. And those numbers come from our patients. We don't make these numbers up. We get them from the patient. So 99.6, which rounds up to 100%, for those of you who like math, 100% pain relief with this surgery for disc pain. So, what's important for you to understand is that this is the most successful surgery in the world for getting rid of pain in your back from a disc problem. Degenerated disc, herniated disc, bulging disc, ruptured disc, protruding disc, extruding disc, you name it, we fix it. On the other hand, this surgery will not get rid of pain from your SI joint, shot. It will not get rid of pain from your piriformis muscle. It will not get rid of pain for your facet joint. So the facet joint, turns out that it causes pain in 45% of patients. That's almost 50% of patients, take it, that have chronic back pain. So if you've had back pain for more than 6 weeks, there's a 50% chance, almost 45%, that you also have pain coming from your facet joint, not just your disc. So I check everybody that comes here for facet pain. I check everybody that comes here for piriformis pain, and I check everybody that comes here for SI joint pain. Shot? Mm-hmm. Because the facets, SI joint, piriformis, wait, are all very common causes of back pain besides the disc. Shot? All right, we're going into 5-1, and Five one is the hardest to do. She's already got pinched nerves pretty bad, and she's probably going to still have numbness, tingling, weakness, all of that afterwards. It takes time for nerves to heal. If she's lucky, the symptoms will be gone when she wakes up. If she's not, it'll take probably a few months for those symptoms to heal. Got a Raytech down. Everybody's got, different healing. And healing is one thing we cannot speed up at Deuk Spine Institute. Nobody can. There's no medicine that makes you heal faster. I have that question asked all the time by patients. Dr. Deuk, what can I do to heal faster? Well, I'm not aware of anything. There may be something out there. I wouldn't be surprised if there was, but I don't know what it is. And I don't like to experiment on people, so I'm not going to ask my patients to take things that I don't know is going to help them. I'm not that kind of doctor. But that said, if somebody finds something that helps them heal faster and they tell me, great. We've had a couple of patients say that they use muscle stimulation, basically external pads that connect to a TENS unit, and they love it. They say it helps. That's because it's muscle. Muscle is really what takes the longest to heal after surgery like this. Muscle and nerves. And those are two things we cannot heal with surgery or medicine at Deuk Spine. So, all right, Henry, we'll take your questions.
This next question comes from Samir, once more on YouTube,
Hello, Samir.
asking for cervical. Do we have to wear a collar for a couple months after surgery?
Yes. For cervical Deuk laser disc repair, you have to wear a collar for 6 weeks. 6 weeks. And I could tell you, the people who have reherniated, which is 1%, 1 in 100, they don't wear the collar like they're supposed to. They take it off and leave it off. And then they have a coughing fit or a sneezing fit, and then they can reherniate. So my advice is wear your collar, wear your brace for 6 weeks, and then you can take it off.
This next question comes from Joe, who asked the first question from before. And they asked, does end plate sclerosis or modic changes have any effect on healing time of the annulus?
That's a great question. So Joe is asking a really good question. He's basically saying, Dr. Deuk, if somebody has a really degenerated disc, does that affect the time to heal the annulus? And the answer, Joe, is number one, I don't know. I don't know for sure. Now, you may think it would, but it doesn't necessarily mean that it would take longer, because it might actually be shorter. Here's why. If you have end plate sclerosis, modic changes, it means you've got advanced degenerative disc disease, right? And we could still fix your pain and symptoms from degenerative disc disease, but when you have advanced degenerative disc disease, that means you've got more inflammation in your disc. And I can tell you this right now, more inflammation means you're going to heal faster, right? Because you need inflammation for the first week of healing. So having the modic changes and the degenerative disc disease is not necessarily a bad thing for healing, okay? That's number one. Number two, because the disc is collapsed more, you might actually heal faster. Why? Because think about it. Your disc now is pretty much 50% or more gone, so your bone end plates are closer. Well, your annulus heals from end plate to end plate. And because your disc is now collapsed, you're probably going to end up healing faster, because there's a shorter gap, a shorter distance to heal, right? It's just like if you were to run from point A to point B. If you make A and B closer, then you don't have to run as far. So the healing that's taking place is going to be faster with a collapsed degenerated disc. So there's two reasons why you can argue theoretically that degenerative disc disease actually heals faster than somebody without it. The disc height is shorter, so the distance to heal is shorter, and the inflammation is greater, so you have a head start on the healing. On the other hand, somebody with an annulus that is more intact, less degenerated, might heal faster because, well, they've already got a good annulus. They just need to extend it out. So the truth is, I don't know the answer. And by the way, for those of you who've never worked with me before, I have no problem telling you when I don't know something. I'm not ashamed of not knowing. I know a lot more than most doctors in my specialty about the back, so not knowing something doesn't embarrass me. I just don't know. And I'll never tell you I know something when I don't. I like to be honest with people and truthful, because I respect people, and I want them to know what I know, and nothing more and nothing less. Now, what I have problems with sometimes is time. I don't have time to sit down and spend an hour with every patient talking about theories. That's why I do it during surgery. So if you want to know things, ask me during surgery, like right now, because I can tell you while I'm operating, because honestly, it's kind of like playing a video game. It doesn't take a lot of brain power to do what I'm doing right now. Therefore, I can allocate some brain power to answering questions. Next question. Almost done here. I got about 3 minutes left at this disc.
This next question comes from, I love this name, Mama on YouTube.
Mama. Oh, Mama. I love it.
Mama.
Is that an Italian Mama?
It just says M-A space M-A, so I'm going with Mama.
All right.
Mama asked, when the tear is cleaned out, why doesn't new disc material squeeze out into the annular tear cavity that you cleaned out, causing the same original issue?
Yeah, Mama. Great question. We get that question a lot. The answer, Mama, is that the disc material is not water. It's not liquid. It's solid. And it takes squeezing hard to get it out. Think about your toothpaste. You have a bottle of toothpaste, you take the cap off, doesn't mean it's going to leak out, right? Your toothpaste won't leak out. You can leave the cap off, and it won't come out. The toothpaste won't come out. It'll just sit there. The only way to get the toothpaste out when the cap is off is to squeeze the bottle. Squeeze it hard. That's what you have to do with your disc. You have to squeeze your disc. And the way people squeeze their disc is by bending over and by carrying heavy things. So everybody that has this surgery gets restrictions for 3 months, actually for a year, where they're not allowed to bend over for 3 months. They're not allowed to pick up anything heavy for 1 year. That's how we prevent the disc from reherniating. It's the patient's job. There's nothing else that works, by the way. We've tried all kinds of things over the years. For the last 30 years, 40 years, doctors have tried putting all kinds of plastic things and collagen and all kinds of animal products in the disc to try to get it to seal. But none of it works. Even this disc seal stuff is garbage. Doesn't work. We have lots of patients who try it, doesn't work. I don't do disc seal because it doesn't work. I told you I'll never do surgery I don't believe will work. I don't care how much you pay me. I will not do surgery that I think won't work. So that said, you can see right there, nothing is squeezing out. Nothing is leaking out. Okay? The disc material here is thick, hard. It's not hard, but it's soft and spongy like a piece of shrimp. But it's not just gonna come out. I'm almost done. I want to grab and see if there's any more pieces of herniation that are loose. And man, that's a tough one. The angle on this disc is tough. Hold it. I think we're done. I just got to get the corner here, the last corner, and we're done. Now, remember, my surgery, this surgery here you're watching, will never make your disc normal, ever. Don't expect all your herniation to be gone. It won't be. You may not even see a noticeable difference on the MRI. That's totally normal. We're not trying to make your disc look normal structurally. By the way, if MRIs told us where pain came from and it was abnormal structures on the MRI, then every patient in the world would be out of back pain because every doctor would know exactly what to fix. The reality is MRIs never tell doctors where pain comes from. Never. And if you rely on the MRI, you will find that you're wrong 99% of the time. You cannot diagnose the cause of back pain from an MRI alone. All right, we are pretty much done right here at 5-1 on the left. I don't see anything left. A little bit of calcium and bone spur here, but it's not pushing on anything. I'm happy. It looks good. Always check lateral. If you do this type of surgery, don't neglect the lateral stuff. This is the outer half of the foramen and the extraforaminal zone. Looking good. One time very early in my career of endoscopic surgery, I didn't check over here, and the patient actually had a lateral herniation. And they left and they came back the next day and they were having pain, and I said, I don't know why, let's get an MRI. And sure enough, I never got the lateral herniation out. There was one time that happened to me, and I never made that mistake again. There's the nerve, by the way. We're just underneath it. Okay, that's how close we are. Scope off. You're welcome to ask more questions. I'm done with the left side. I'm going to the right side next. We've got 2 discs on the right side to fix. Henry?
So sorry, no current questions at this moment.
All right, very good. So far, this patient is doing really well. She is snoozing. From an anesthesia standpoint, she is in happy land, right? Her vitals are stable. We've only lost maybe a cc or 2 of blood. We've already finished 3/4 of the surgery. You ready? So she's sailing through and doing great. Our first patient's already gone home. We didn't broadcast that one because the patient didn't want broadcast. So what do you want to do first? 4-5? So I've really gotten into growing orchids lately. I've ordered some orchid media, some bark, some sphagnum moss, some perlite.
I hope all that stuff's hypoallergenic for you.
Huh?
I hope all that stuff is hypoallergenic for you.
Thank you. I hope so. But I've always wanted to grow orchids. Shot? They're not easy for those of you who have grown plants. They're kind of hard. Shot?
I like when all those plants grow.
They are.
Very fastidious.
But that said, I've been doing a lot of YouTube videos, which is very helpful. And I feel like I've learned a lot from the experts. I've got a couple of Vandas. I've got a shot. Huh? What?
Stuff you got me about the last patient, for the doctors for
Let's see. So, Flomax to the first or next?
Last case. The last case.
Ah.
He got full max last case.
Oh yeah, please. We don't need a I can't pee-pee problem. Huh? Oh. 100% Flomax. Okay, we are entering the disc. Hold on. Let me just verify. Go ahead. Wonderful. Felt really good about this. She's got no body fat. She's in perfect shape. So I just have to try to get as far lateral as I can safely, and in order to get into this disc. You can see, for those of you who are astute, she has a spondylolisthesis, grade 1, right? Jordan, you want to show the audience that? Yeah. Can you see that, Henry?
Yes, we can.
So that L4 is slipping on L5 by about 5-6 millimeters, no big deal. Most surgeons will tell you, hey, you have to have a fusion for that. We don't do a fusion. I used to believe fusion was the only way to fix the pain from the L4-5 spondylolisthesis, but it's not. I was wrong. That's what we're taught in our training. You have to do a fusion. But the reality is, my laser patients that have spondylolisthesis do better than the fusion patients. Much better. Look at the inflammatory tissue, how pretty that is. Pink and blue. You guys see it?
Yes, we do.
There's little nuggets of granulation tissue there. That's where her pain's coming from. Folks, that pink tissue in the annular tear, called granulation tissue, is the source of the back pain when it comes to spondylolisthesis, not the spondylolisthesis. So I'm going to just clean out this tear with the laser, and you'll see the pain that she has at L4-5 will go away. I have never had a patient with a spondylolisthesis that I did this laser surgery and they didn't get rid of their pain from that level. Okay? Never. I've done 1,000. Spondylolisthesis does not cause back pain. Bone on bone does not cause back pain. Degenerated disc does not cause back pain. These are all things that are taught to patients that are not true. Now, people with degenerated disc can have back pain. People with spondylolisthesis can have back pain. People with dogs can have houses, or they can have apartments. But the fact you have a dog and you have a house have nothing to do with each other. The fact you have back pain and spondylolisthesis have nothing to do with each other. As a matter of fact, there are millions upon millions of people walking around with spondylolisthesis and no symptoms of back pain and no symptoms of leg pain. And guess what we do for them? Zero, zippo, nothing. We don't treat them. I would never treat, and nobody should ever treat, an asymptomatic patient who has no physical exam findings of weakness, numbness, nerve compromise, or symptoms of radiculopathy, radiculitis, or back pain. You should never treat them with surgery just because they have spondylolisthesis. A lot of misinformation out there, folks. And by the way, doctors are still promoting misinformation. I don't think they do it intentionally. Some of them probably do. But most of them just are ignorant of the truth. That's why we do our broadcasts. We don't want people being ignorant. Right? If you have a problem, you don't want to be ignorant about it. You want to know the truth. That's why we do our broadcasts. We want to inform people of the truth. So if you can't trust your doctor to give you the truth, at least you can trust us to give you the truth. Any questions?
Yes, we have two other questions. This first one comes from Barry on YouTube, asking, what are alternatives other than the MRI for locating the issue? I have been having back pain, I've been having back pain for over 2 years and just now getting checked, and an MRI because my part of my right hand is getting numb.
Gary, the very best thing you can do, and anybody in the world can do, is have your MRI looked at by Deuk Spine Institute to get an answer. Okay? But it's not just your MRI. We need to get some history. We need to do a physical exam, which we can usually do on Zoom. Okay, so wherever you are, set up a free MRI review with me, and I will be able to tell you probably why your hand is getting numb. Now, sometimes we have to do a nerve test. A nerve test is a special test done on the arm to check the nerve function. There are several causes of numbness in the hand. Okay, one of them is a pinched nerve in your neck from a herniated disc. Another is an irritated nerve in your neck from a herniated disc. Another is a problem in your brachial plexus inside your neck. You could even have what's called thoracic outlet syndrome. Another is a pinched nerve in your elbow. Another is a pinched nerve in your wrist. Another is a pinched nerve in your forearm. In the front part of your forearm, the back part of your forearm is another one. Up in your shoulder can get pinched. You can have a tumor in your lung called Pancoast tumor, which can cause, Pancoast syndrome, where you have a pinched nerve in your brachial plexus from a lung tumor. There's so many causes, and it's not one test. It's a smart doctor. It's an expert like those of us at Deuk Spine. We can figure out what's wrong. So don't waste your time with local doctors. Send your MRI, fill out our form, get a free Zoom consult. Get some answers. Otherwise, you could spend years with other doctors trying to get answers, and you'll never get the answers. My advice is go to the best. That's what I've always done. Look at that inflammatory tissue. You guys see it, the pink that I just blasted? This is scar tissue. Go ahead. My personal philosophy in life is too short, and you're only given one spine. So go out and get the very best. If you need brain surgery, do you want to go to the Walmart of brain surgeons? Do you want to go to the Walmart of brain surgeons and get cheap brain surgery? Or do you want to go to the best? I hope that that's an obvious answer for everybody, right? I hope some of you aren't saying, I'll go wherever my insurance sends me. You're going to go to the best in the world. The doctor who's going to take the most of that tumor out to give you the best results without hurting you, causing complications, and a quick recovery. If you've got a brain tumor, you want a quick recovery. You don't want any complications from surgery. You want a fast, excellent result. You want the best humanly possible result. So you want a cure if you can get it. And there are surgeons that do a far better job at brain surgery than others. I'm not one of them. I'm a brain surgeon, but I'm not the best in brain surgery. I would send people somewhere else if they came to me. Okay? What I am good at is spine, and there's nobody better. And I'm not trying to be bragging, I'm just being honest. I spent my last 30 years of my career perfecting spine care and doing things no other doctor has done in terms of learning and educating and preparing. So don't waste your time with local doctors who can't give you truthful answers. Go to the best. We offer it for free. We offer it virtually, so you don't even have to leave your house. You just do our MRI review from the comfort of your living room or kitchen, okay? Or the boat that you're on, stationed out in Iraq. We have plenty of military. They do a Zoom conference with us. They're overseas, they're stationed. We have star athletes. We have bankers, investors. We have billionaires. Everybody comes the same way. Most of them want to do a Zoom call and figure out what's wrong and how to fix it. And once they understand how we're going to fix it, they come here to get it fixed because they like our treatments better. All right, we're just about done here. I appreciate the questions because it gives me something to think about while I'm working. If you're wondering, some people sometimes say, Dr. Deuk, how do you operate and answer questions at the same time? Well, that's how medical education works. Medical education at the hospital works because the surgeon who's teaching is teaching the surgeon who's learning while they're operating together. They're talking. They're showing each other things. And I'm showing you guys so you guys can learn. Look at that herniation that just popped out. You see that, Henry? That was a
Yes, we
piece
did.
of herniated nucleus pulsus stuck within the annular tear. So that's why we do an annular debridement. As long as that stuff is there, it's going to keep causing damage and pain. So I was really lucky here. I actually got all the way across to the middle of this disc. You guys see where the laser fiber is way down there? That's the middle of the disc. That's how deep we are. I've gone all the way through the annulus. We're right up against where the herniation is. So this is wonderful. We're treating her stenosis of the foramen. We're treating the stenosis of the central canal. And we're treating the lateral recess stenosis all in one. Okay? And she needed it, by the way. That's why I did it. Any more questions? I've got one disc left.
Yes, this next question comes from Angie on Facebook, asking, "This is so interesting to watch. Do you have to do something like this for a bulging disc protruding onto the spinal cord?"
Yes. Yes, Angie. We do the same surgery for bulging disc, protruding disc, extruding disc, ruptured disc, lip disc, herniated disc, extruded disc, and even when it's pushing on the spinal cord. We do it in the neck. We do it in the thoracic, and we do it in the lower back. We're the only company in the world that does those three. That's why you should come here. Okay, there's the tear. It's about 3 millimeters again. 1, 2, and 3. So it's around 3 millimeters wide. And that will heal beautifully. Her nerve is up there in the fat. I'm happy we're not seeing it. I'm just looking around. I don't see any more herniation. Maybe a little bit right here, Luis. That may be some herniation. I just want to get that real quick. But yes, we do this surgery on the neck as well. All right, that went down really nice and quick. We're done. One more disc to go. Great questions. Keep them coming. This is the safest, most effective treatment in the world for back pain, neck pain. People are still being told that back pain is not curable, that it's non-specific. They have fibromyalgia, but none of that is true, folks. We can now cure chronic back pain, okay? Why do I keep saying chronic? Chronic means you've had it for more than 6 weeks. Some people say 8 weeks, some people say 3 months, but chronic basically means pain that is not like pain you just got yesterday, right? Nobody needs surgery necessarily for pain you just got yesterday unless you have a tumor, fracture, infection, or instability. So we say chronic pain because we don't want people who just started having back pain for a day. We don't want you coming here and getting surgery. You're supposed to get other things done first, and most likely you don't need surgery. Not everybody that has acute back pain needs surgery. All right, so here we go. We've got our guide wire. I'm taking the needle out, leaving the guide wire in. The guide wire will guide the dilator. The dilator will create a space for the tube. Hold this. Called the tubular retractor. All right. So far, she's doing great. 3 discs down. And 1 more to go. Just giving her some numbing medicine. Shot. It's funny, we had somebody say the other day, I'm not having that surgery Dr. Deuk does because he bangs that metal spike into the spine. And I laugh about it because the banging of this metal spike into your spine is like literally on a scale of 1 to 10 for normal back surgery that you guys don't get to watch because surgeons don't show you. It's literally a 1 out of 10. Like the things we do with open back surgery are 10 times worse. But you just don't see it because surgeons will never show you how they do back surgeries. I mean, I do. If you go to our YouTube channel, you can actually watch my spinal fusions. I used to do a lot of spinal fusions.
Those are love taps compared to the air guns.
Huh?
Those are love taps compared to the air guns.
Hold on.
Right?
Yeah, these are, hold on. These are love taps. That's correct. Let me see. Shot. All right, take it out. Yeah, her nerve is really irritated on this side. This side is pretty bad, huh? No, you don't need to do anything. It's not her back muscles. It's where literally the herniation has created such narrowing in the foramen at 5-1 on the right that the nerve has no real room to get out. So we're like literally underneath the nerve competing for space. But there's no other way around it. You've gotta get in there and get the herniation out. So yeah, this nerve is very irritated.
This was the level where she was at.
Hmm?
She was uncomfortable with this one.
Yeah.
More than any other one.
All right.
I was saying it seems like this level was more inflamed than the other
Oh
levels.
yeah. Yeah, this right 5-1 is her worst one. And you can see the herniation right there. Laser?
We have another question.
Sure.
This comes from Joe, once more on YouTube. asking, do your patients having nociplastic type of pain from fibromyalgia symptoms like allodynia report more pain after surgery?
No, our patients do not report typically more pain after surgery. Our patients have less pain, and they usually have zero pain where we're treating the source of the pain when it's the disc. The problem with some of our patients is that they have other causes of back pain. For example, the patient we're doing last today, he came here from New York about, a month and a half ago? He had pain coming from his discs, L2-3, L3-4, L5-S1, and his facet joints on the right, L2-3, L3-4, L4-5, and L5-S1. We fixed those discs and the facet joints, but he also had pain coming from his piriformis muscle and his sacroiliac joint and his trochanteric bursa. So he came back and he said, "What do I do?" And I said, "Well, we were hoping that this would go away on its own after we fix your spine, your disc pain." Of course, it did not yet. And I said, "Look, we can do more shots or we can do a permanent surgery." And so we're going to be going in and doing bilateral piriformis release on him because he's got a bilateral piriformis syndrome, which is a torn muscle in the buttock. And a lot of people that have chronic back pain, they bend and lift things improperly, and they end up injuring their piriformis muscle. And then they get horrible pain in the low back, just above the buttocks, at the top of the buttock, and that's a piriformis syndrome. And you can diagnose it because of the location of the pain. You will not see it on the MRI. So he's back to get piriformis release done, and he's back to get SI joints done. Now, I don't do the SI joints. Dr. Patel does. So I will not be doing his SI joint. I'm waiting for Dr. Patel to get back in town and do his SI joint. But today we're going to be doing his piriformis releases, and we're going to do his rhizotomy of the facet joints that are hurting him on the left side. So last time we did right rhizotomy, facets, and we did the discs, Deuk laser disc repair. This time we're doing piriformis muscles, and we're doing the facets on the left side. And that's where his pain's coming from. So when you ask about pain after our treatments, it's always from something other than what we treated. We have very rarely missed our target, and never with the laser. The only time we've ever had trouble actually curing pain from a structure that we're treating is with the Deuk plasma rhizotomy, is when there's so much arthritis around the facet joint that it's really hard to get to the medial branch of the dorsal ramus, which is the pain nerve, to sever it. It's buried in scar tissue and bone spur. So we've had a couple of patients, honestly, like probably less than 3, maybe 3, that we've had to repeat 1 or 2 joints, say out of 5 or 6 that we did, because those joints were just covered in scar tissue and bone spurs, and we had to go back and redo them. But that's maybe 3 out of 300, so 1%. Oh, it's not common. So when you ask about residual pain, there's definitely residual pain if we've not treated a structure that is painful. And we're pretty good about identifying the sources of pain ahead of time in clinic before they do surgery, before the patient does surgery. However, we're not perfect. And the reason why we're not perfect is, to be honest, the patient may not be having pain there, right? At the time that we're evaluating them. So for us to diagnose a pain source in somebody's back, the patient has to have the pain at the time we're evaluating them. And the reason for that is MRIs don't tell you where pain comes from. X-rays don't tell you where pain comes from. Nerve test doesn't tell you where back pain comes from. There is no test in the world except the discogram can help you, but it won't tell you where all the back pain comes from. It'll only tell you if the disc is causing pain. All right, just about done. Man, this disc was pretty messed up. Look at all that scar tissue there. This is the one that was pinching on her nerve down her right leg, the worst. It's going to take time for that nerve to heal. That's one thing I can't do. People want to know, when is my numbness going to go away? When is my weakness going to go away? When is my pain going to go away? Generally, pain goes away within 2 weeks if it's from the pinched nerve, but weakness and numbness can take a year or longer, even in some cases, to go away after your surgery. Just about done. Probably 3 minutes, Dr. Berndes. A lot of scar tissue here from inflammation. Yeah, I'm going to try to grab that huge piece of herniation out. You can see it way down there. Any more questions?
Yes, we have a couple more questions, but this next one comes from, excuse me if I pronounce this wrong, Diraj on YouTube.
Yep.
Diraj asked, have lower back pain since 6 years ago, pain only when sitting for long and standing that time. No numbness in leg, but still have pain.
Yes.
Doctor suggested to fix my spine through screws and rods. How is this laser treatment different from spinal fusion?
Diraj, your doctors are offering you spinal fusion because they don't know how to do the surgery. This is the newest, most advanced treatment for your problem. You do not need screws and rods. As I said earlier, I used to do screws and rods all the time, every week, 5 to 10 fusions a week, because that's what we thought was the only way to fix your problem. But we can now use the laser instead. It's far less invasive. The reason why is because I know exactly where your pain's coming from. It's coming from a small tear in the back of the disc, and I know how to find it, and I know how to identify it as the source. But to get 100% confirmation, you need to do an MRI review with me. So you need to fill out our form, and you need to meet with me on Zoom. Let me examine you, let me look at your MRI. By the way, that whole process is free. We don't charge. There's the herniation. Oh, it ripped in half. You guys see that?
Yes, we do.
I'm trying to get it out. It's just so big. This is what was crushing her nerve for a long time. That's why her nerve is so irritable on this side. Oh, here it comes. Come on now. Oh, yeah. Oh, it ripped again. Get ready with the lights. We're going to show this herniation. This thing is going to be big. Remember, the inside of this tube is 5.5 millimeters. Ah, ripped again. Can you see this, Henry? How big this thing is?
Yes, we can.
Damn. Well, I keep tearing off little pieces, but eventually it'll be able to fit. Almost done, doctor. Ah, keeps tearing. Damn it. Well, keep the questions coming while I work on getting this big herniation out.
This next question comes from Big John on YouTube.
Ah, Big John.
They asked, would you have any suggestions for what type/kind of bed or bedding and pillows that a post-op lumbar/cervical surgery patients should use or not use?
Big John, I honestly don't know. I am sorry that I cannot be more helpful. I don't know. Now, that said, I can help you because I don't know, but I know somebody who does. Her name is Dr. Schrumpf. And she, oh, here it is. We got it. Oh, here it comes. Watch this, Henry. Get that camera.
Got it.
Holy macaroon. Whoa! There it is. Look at that thing. Dude. I love a good giant herniation. She's going to love watching this, huh? Can you see this thing?
Yes, we can.
This is a good one for the website, Henry. A really good one. Look at the size of that herniation. Huh?
Perfect.
Yeah. So let's take a look at this thing for a second. All right, number one, look at all that scar tissue right there. You see it?
Yes,
Some
we do.
inflammation. Number two, there's still some inflammatory tissue right here, the red stuff. You guys see it?
Yes, we can.
This is a beautiful herniation. And it's huge. Let's just do inches today. Check the size of this thing. That's like more than an inch. Inch and a half almost. Okay? That just came out of this tiny little tube. That is a giant herniation, folks. Beautiful. Keep that for the website. That's a good picture for the website.
You got it.
That's why her nerve was getting crushed from that thing. We should be done very soon, doctor. Let's just see what we've got left in here. Big John, Dr. Schrumpf. She's the one. She's an expert at beds, pillows, sleeping positions. We can hook you up with her when you come. Talk to your scheduler and ask about, there, look at that inflammatory tissue. Ask about Dr. Schrumpf. 2 minutes left and I should be done. Unless there's another big herniation. So there might be. Something is moving around down here.
This next
Yeah,
this next question comes from Roscoe on YouTube.
Roscoe.
They,
Grab your Roscoe.
yes. They asked, can patients return to golf after a lumbar disc annular tear repair?
Can patients return to golf after a, I assume you mean a Deuk laser disc repair?
I believe so, yeah.
Yeah.
That's what
My
I think.
surgery. The answer is yes. You can go back to putting in 2 weeks. You can go back to your mid-game, your fairways in 6 weeks. You can go back to a full game of golf with hitting and driving the ball in 3 months after your surgery. 3 months. That's all it takes. 3 months. Absolutely. By the way, thanks Roscoe for asking, but there are no long-term restrictions. If you get the Deuk laser disc repair surgery you're watching right now, get this done, you wait a year. At the end of 1 year, you can do anything. You can go on that ride where they fling you into space between those two giant poles. The slingshot. Anybody do that slingshot ride?
I haven't, but I know a few people that have.
My daughter did it. She's 17, Ariana. She has been hounding me to do it. And she keeps calling me a wimp because I'm avoiding it. And I hate to say it, but she's right. I don't know why. I used to love like those kind of rides, you know? But the reality is I'm afraid. It's kind of a fear that is not really justified, right? Because, I mean, after all, how many people die on those things? They don't. So I should be willing to do it. It's just hard to get myself to do it. So, anyway, anybody do it? The one in Orlando? It's literally 5 minutes from where our new office is going to be, the Orlando location. Our Orlando location will be right next to Universal Studios and the mall at Millennia. Expected to open now instead of December, probably February of next year. January or February. I'm sorry, Dr. B, there's just so much herniation here at 5-1. I'm trying to chop out as much as I can. Almost done. Probably another minute if I just get these pieces out. Any other questions, Henry?
Yes, this next one comes from Diraj once more on YouTube. And he
Alright.
asked, how much cost will go for laser treatment? I am here in Florida, so can plan, but need to know the cost. I have Anthem insurance. Is this treatment covered in Anthem insurance?
So Diraj, to answer your question, number one, is any treatment covered by any insurance? You don't know until you do the treatment and you bill them and they pay, right? That's the God's honest truth. It should be covered. We expect Anthem to pay, and if they don't pay, we're going to fight them to get them to pay. That said, I don't know how much your treatment would cost because we don't know what treatment you need. We haven't done your MRI review. We can't tell you what treatment you need until we've done your MRI review. But I could tell you the cost is related to how many discs we're fixing. Are those discs lumbar, cervical, or thoracic? Are we going on both sides or one side? And the cost is proportional to those things. So the cost is going to equal how many discs, what areas, and what sides. To find out what your cost would be, you need to do an MRI review. So Henry will post the free MRI review. It's no charge, and I recommend you get it filled out and done. All right, we may still have a piece of herniation right there. I'm looking. There's a bone spur. How are we doing on irrigation? Good? Because it looks like we're almost out. It's good? My God, so there's tremendous amount of herniation on this right side at L4-S1, all crushing her nerve. I'm removing it all, debulking it. Remember, we're not going to get 100%. When I say we're removing it all, I don't mean all of it. I mean we're removing as much as we can. But as much as we can is definitely not going to be 100%. It's going to be probably 50, 60%, but that should be enough to get her out of symptoms, and that's for the rest of her life. There's no surgery in the world that does 100%. Even when you take a brain tumor out, we can't get 100%. We get about 90. We have to leave the rest and radiate it. Sometimes we get a lot less than 90. All right then, that should be it. This is definitely the worst, Dr. B. Man, look at all that scar tissue. Right there, you see that? I just want to make sure it's just scar tissue and not herniation. No wonder why she was having so much problems on this right side with her nerve root. It was getting crushed by that gigantic herniation. That thing was impressive. All right, folks, type up your questions. I'm pretty much done. I'm going to leave the operating room. I'm going to come over there and answer your questions for you. So this is your chance to talk to me face to face. By the way, that's fat right there. That's the foramen. We're just at the end of the disc right here. I'm trying to get rid of as much as I can. This is probably the oldest part of her herniation, by the way. See all that golden color? That's all old inflammation. So when she said everything started 7 years ago, this is where it started. This was the original injury. Right here. Let me just grab in there, make sure there's nothing else. Sometimes you get surprised. Oh yeah, there's something else right here. Yeah. Okay, so it wasn't just one giant herniation, it was actually two. Holy mackerel, man. Again, it's breaking apart. So I'm glad we looked. This is it right here. That thing's huge. Not sure what she did to blow out her L4-S1 so bad. Alright. This is not quite as big as the last one, but it's not that much smaller. Here it comes. Yeah, there it is. Show us. Can you guys see this, Henry?
Yes, we can.
Compared to the last one, it's not about a third as much. You guys see it right there? It's pretty good though. But that should be it. Let's go back and look and make sure. I didn't really see anything else. Let's see. Yeah, look at that. Now we got some bleeding, which is good. That means that we've gotten all the pressure off the veins. There's a little piece. We're done. Let me just grab that. All right. Pretty much done. All right, so great surgery. Honestly, did not expect the herniations to be that big, but they were huge on the right side. So I'm glad we looked and persisted. Sorry. You know what that is? That's from here. All the irrigation going through to the other side. How funny. Sorry, Luis. You okay? Yeah. I would do a pressure dressing because we just don't want anything swelling. It's probably the irrigation mostly. Once you get a herniation out, folks, it really decompresses the veins that are in there. Pressure. And the veins open up and they get engorged. And we call those veins Batson's plexus. I need one. Scope use is an 8. Blood loss is a 7 milliliters. All right, so we'll put a little bit of pressure. Keep the pressure there. Here, I'll hold it. And move your hand. Because we're operating on both sides of her spine through the same disc, the liquid from the right side that I've been putting in there has gone out to the left side through the disc. So I'm just applying a little bit of pressure to her muscles. She's very muscular. Muscles have a lot of blood supply. Yes. I'll hold this while you go clean up a little more. Muscles have tremendous amount of blood flow. And when you combine the muscles plus the epidural veins from all that inflammation in the back of the disc that are supplied by the tributaries are the epidural veins, you get a lot of blood circulation in the area of a herniation due to the inflammation. So when we get in there and take the herniation out that's causing all that inflammation, it basically uncorks the bottle and it allows the veins to bleed. So it's usually minor. You guys see the incision there?
Yes, we do.
Yep, there it is. So the whole incision is about, well, I did about 8 millimeters on this one. But it looks good. All right, Henry, why don't you show them one of our patients, and I'm going to head over there and answer your questions for you. Okay?
And good morning, I'm Dr. Deuk here at the Deuk Spine Institute with a patient who's traveled 10 minutes from Merritt Island, is that correct?
I'm in Vieira.
Oh, Vieira, just down the street. Okay, local. You just had the Deuk laser disc repair on your lower back yesterday for a herniated disc at L4-5. It was a foraminal herniation, and it's one that is tough for doctors to find and discover. But we saw it at Deuk Spine, and you were having horrible back and right leg pain. That was yesterday before your surgery. Here you are less than 24 hours later. How do you feel?
Wonderful. Walking straight. I feel no leg pain, no back pain, just a little sore, but that's about it.
How long have you had the back and leg pain for?
Since 2012, 2013, since my surgeries.
You live with pain.
Right.
He had, I guess, a microdiscectomy done. Correct. Did that fix him?
No, a month later he was back in surgery.
What kind of surgery did you have done?
The fusion, S1, L5.
So you had an L5-S1 fusion, good. Did that fix your problem?
No, not at all.
And their suggestion was take the metal out, and that they already seen that he had a problem with the disc above that one, so let's take the metal out first, then within a year go back and do another fusion on the disc above that.
And that was the metal they put in you?
Yes, sir.
So they put metal in you for the fusion, and then they told you afterwards, well, we got to get it out because that's what's causing your pain.
Right.
Kind of silly, isn't it?
Yes, sir.
All right, glad I'm not the only one that thinks that's a bit silly, but that's right, it is silly. And it's not just the surgery, the fusion. Didn't you have pain management and stuff in between?
Yeah, so I had shots and a nerve specialist do some stretchings and hands-on stuff, but that's about it.
So you had shots, you had therapy, and then you had surgery, and you had more shots and therapy. And that's the problem is you're like I think about it as like a washing machine going around and around, and they're just washing the money out of your pockets and washing your life away because your quality of life has not been good, has it?
No, not at all.
How did you find Deuk Spine Institute?
My wife.
I couldn't believe it, amazing. Last time he had surgery, 9 days, he couldn't even hardly move. And I mean, he was up last night pacing the floors, antsy, trying to find something to do.
This must cost your family a lot of money dealing with the pain.
Oh yeah, well, and it cost him not just, with the pain, he's not able to do the stuff he likes, fishing, throwing the baseball with our son. So just just doing life things he's not able to do that because of all the pain that he goes through. So now we're just so grateful that we found you guys because, I mean, I have not seen him walk like this in 19 years.
And that's just one night.
Yeah, that's just one night.
And
so,
no pain meds.
No pain meds, no anything, no medicine. He had took no medication whatsoever last night.
So just to recap, your husband, like millions of people, had back pain. He went and had microdiscectomy, which is a procedure where the surgeon basically ruins the back of the spine in order to get to the disc. That caused instability, which then he needed a fusion done shortly afterwards, right?
Yes.
You said a month later?
Yes, a month later.
And then you went back again because he was still in pain and worse after the fusion.
Right.
And they told you he needed another surgery, a third one.
Correct.
To get the metal out.
Right.
And then he was going to come back for another fusion after that.
Correct.
And then there would be more fusions and more fusions, right?
That's never ending.
Never ending. And we see this all the time with people that have open back surgery, invasive back surgery. Is a cycle of over and over, more and more surgeries. Well, he's done now.
Yes, thank you. And we're so grateful.
We have one more muscle thing to fix and then we're done.
Yeah, you might have to do something to me so I can keep up with them.
You ended up having faith. You had the surgery done yesterday. You can see in the video, we made a tiny little cut, just 7 millimeters on your back, and we got the whole surgery done. We found the herniation, we cleaned out the tear. And while you were in there, I tested your disc at L4-5 above your fusion, the one that's bad. You had 10 out of 10 pain. And I asked you, is that your typical back pain?
I heard that.
Yeah, and you said yes. So you're going to watch your surgery today. We gave you a video. Henry did a great job recording it and broadcasting it. But you're happy today. You've had your back fixed.
So I'm walking straight.
You're walking straight.
Walking straight, not leaning.
And do we have you on pain medications at all today?
No, nothing.
You didn't take any, did you?
Nothing.
You didn't need
Zero, nothing.
Yeah, with the cut on your back being that big, it's a Band-Aid. There's no trauma inside your body we're doing, so there's no need for pain pills. That's one of the nice things about Deuk laser disc repair compared to open back surgery like fusion, is that we don't do trauma inside your body. There's no need for pain medicines afterwards.
The fusion caused hernias, and I had a hernia surgery.
Really?
Yeah, because of the pain pills.
So all the complications from fusion, including, I've not heard that one, having to have a hernia surgery on your groin, right? Wow. So there's another complication from fusions. Well, you're not going to have that problem anymore, are you?
No, sir. Hope not.
Well, is there anything else you want to share with your fans out there who are listening to your story?
The best thing that's ever happened to me. I'm walking straight, no pain. I feel like I can go do what I usually do, and especially fishing.
Yeah.
I miss that.
We're going to get you there.
Thank you, Deuk. Thank you.
It's my pleasure. Get back to fishing.
Yeah.
I just want everyone to know, please make sure you educate yourself before you do this because, you only have one life and you want to make sure you live it to the fullest, and doing these back surgeries that these doctors recommend is not the way to do it. You need to come here And I mean, at least just give it a shot. Let them look at your MRI. I think you said you can do the reviews online if you don't, out of state. But please check here first and let Dr. Deuk, go through all of your records, because I'm telling you, this is the best thing that we've ever done.
I'm happy for you guys.
Oh, thank you so much. You just don't even know how. Like, I couldn't believe it. My son was like, Dad, you're supposed to be laying down, and he's in there walking around. Like, we couldn't keep him in bed last night. So it's amazing.
Hey, good morning. I'm Dr. R. Deuk, CEO and founder of the Deuk Spine and Deuk Joint Institute. I'm here with a patient who's traveled from Pittsburgh to Florida. And what brought you here to the Deuk Spine Institute?
Well, I have had back pain for so long, and anything and everything we did didn't help. My wife did significant research. We found you online, actually, is how it started.
Excellent. And what kind of procedures did you have done before you came to Deuk Spine?
I've had 5 lower back surgeries, 1 fuse, and the others laminectomies and so on, all within the last 3 years.
And they were recommending another fusion for you, weren't they?
They were. That's when I really began to research other options. When they mentioned another fusing, I absolutely was not going to do that. So that began our research that ended up finding you.
The Deuk Spine Institute. And what we do differently, folks, is we cure pain with one procedure. Patients don't have to keep coming back having multiple procedures and pain management. And that's kind of where you were. You were in that surgery, pain management, surgery, pain management, surgery, pain management, back and forth. And that goes on if you keep doing it for the rest of your life. But you found a way to get out of pain, and you came to Deuk Spine. How do you feel today?
Unbelievable. I have not felt this good in years, several years.
And you feeling good because we put you on some new pain pill that nobody else has?
Absolutely not. I've lived on pain pills up to this point. I'm on nothing. I have a prescription for some muscle relaxers, no pain pills, and I'm on nothing.
And how did Deuk Spine Institute fix your back?
Had the L4-S1 laser surgery, and then the rhizotomy that was done a few days later. A combination of those two, I'm pain-free. I'm really pain-free.
I'd just like to point out that you, like many people, had more than one source to your back pain. You had discs that were causing the back pain, facet joints that were causing the back pain, sacroiliac joints that were causing the back pain, I think a piriformis that was causing the back pain. And because you were walking so funny, you were getting bursitis and other pain in your leg from the iliotibial band. We had to identify every one of those sources and treat everyone properly. And once that was done, it eliminates the pain permanently.
I have dreamt of feeling this way for years. Teared up a little bit this morning when I woke up. I could get out of bed without holding on to the wall, or it was just an incredible feeling.
Well, I'm very happy for you, and you could see we did your surgery with the laser, cleaning out your discs. Where did you go for your spine care? Was it a good center?
Prior to coming here,
Yeah.
I was at 2 major medical facilities in Western Pennsylvania and Eastern Ohio. Went through a lot of pain with the different procedures and surgeries I had done, and had no relief.
And what were these other facilities, you can say?
UPMC and Cleveland Clinic.
Yeah, 2 of the top spine institutions in the world, right?
Yes.
Great reputation,
Yes.
and yet they couldn't get you out of pain.
No.
And they were just ping-ponging you between surgery and pain management, surgery and pain
That's
management.
exactly what happened. Yes.
And there's no hope for actually getting cured, because they don't have the cure to back pain. We do. Unfortunately, we've been trying to share that cure with them, but they're not interested. They just want to keep doing fusions because, well, let's say it, fusions make a lot more money than laser surgery does. It's hundreds of thousands, if not millions of dollars over your lifetime. That said, I'm glad you're doing well. When are you guys heading home?
Getting on a plane in a couple hours.
All right, very good. Is there anything you want to tell people out there in final remark?
I would just say that Deuk Spine Institute has been a lifesaver for me, literally. I would highly recommend it. I was being ping-ponged around for 5 years. I have dreamt of feeling like I feel right now for a very long time. So I cannot thank you, Dr. Patel, your entire staff. Everybody's been just incredible.
That's what we're here for, my friend.
Thank you, Doctor.
Give people back their lives.
Yes, thank you, sir.
All right, now go enjoy your top golf.
I will now. I will now.
All right, let's get you out of here. And welcome, welcome. Great testimonial from one of our patients who had surgery here.
So there's so much to talk about every day, and I like to keep going over all the high points, the things that people need to remember. I also want to answer your questions, and we also want to obviously do surgery, take care of patients. Now, this patient traveled from Indianapolis, and she is a healthcare provider. That's all I'm going to tell you. She knows spines really well. She's been watching our treatments for years, and she's had back pain for 7 years. It's started to go down into her legs, and it's on both sides. We just completed the Deuk laser disc repair because she had 2 bad discs, and those 2 discs were the L4-5 and the L5-S1, the bottom 2 discs in the spine. And when she told me where her back pain was, she said right here, and I knew that was L4-5, L5-S1. I looked at the MRI, and indeed, those 2 discs had tears all the way across, left and right, from left to right, both sides, all across the back of the disc. And there was pinching of the nerves going on. There was also some slippage of the L4 slipping on the L5, slipping forward. We call that an anterolisthesis, or in general, a spondylolisthesis. Spondylolisthesis means a slippage of 2 bones in the spine. It is not specific for where they're slipping, forward, backward, sideways. But basically, if L4, my fist is L4, L5 is here, let's just say. If L4 is slipping forward on L5, it's an anterolisthesis of L4 and L5. If L4 is slipping backward on L5, it's a retro. Retro means back, retrolisthesis, okay? And if you get a lateral listhesis, that means L4 slipping to the side. And that's what causes scoliosis. So scoliosis is due to a lateral listhesis. Anyway, point is, she had a listhesis, but it wasn't causing her symptoms. Now, most doctors will tell you, if you have a listhesis, you need surgery, you need a fusion. They are wrong. You do not. I have never seen, in the last 10 years, a listhesis that needs a fusion. I've seen grade 1, grade 2, grade 3. You know, when you get to a grade 3 and you're really symptomatic, maybe you can argue a fusion is necessary. But a grade 1 and grade 2, which is 99% of the patients, either you don't need treatment at all, or you need the laser surgery to fix the disc, like this patient had. Surgery went well. You could see we pulled out a massive herniation on the right side at L5-S1. We didn't see the big herniations on the other sides, but that's okay. We had tears, we had inflammatory tissue, we've cured her back pain. Now we're going to cure her leg symptoms. So one question I get from patients who have surgery is, when is my numbness in my legs going to go away? Hey, if I knew the answer, I'd have to have a crystal ball. Everybody's different. In some people, the numbness goes away literally right now. In other people, it takes a year, and everything in between. But there's a bell-shaped curve, and I would say if you look at the median on that bell-shaped curve, it's around 2 weeks to 2 months after surgery. That's where most people, numbness goes away, all right? Weakness, when does the weakness go away in my legs? Typically, the leg weakness goes away in probably two weeks to 2 months as well. The problem is some people don't have leg weakness from the pinched nerves and the nerve not working. They have leg weakness because they have had a pinched nerve for years and their muscles have shriveled up and atrophied and scarred in. And so those people take years for that leg weakness to go away because they have to stretch, they have to walk, they have to do therapy, they got to let the nerves heal. Their recovery is a lot longer, okay? So much to talk about. That's why we broadcast every week so that I can answer questions and give you guys information. All right, I heard we have a lot of questions. Let's get cracking.
This first one comes from Sam on YouTube, asking who manufactures the laser ablation machine you are using?
Sam, thanks for joining us. Who manufactures the laser? It's made by Luminous, which is an Israeli company. They are the best in the world. They make the best laser. They make the safest laser, the most effective laser. Now, Boston Scientific bought Luminous last year for $1 billion. So now Boston Scientific is, I don't know, technically the manufacturer, since they own Luminous. It was a merger acquisition. So Boston Scientific owns the laser and produces the laser machine, but they're really, the people who founded it and created it were an Israeli company called Luminous. That is the only laser I will use. It is the best laser in the world. We just bought 10 of them so we can have them for the future. And the reason we did is because the company that bought Luminous, Boston Scientific, they are going to be jacking the prices up very soon. And we cannot afford, we're a small company, we cannot afford jacked up prices. So we've stocked up.
This next question comes from Daraj, once more on YouTube, asking, can we upload the MRI picture for review, or you need DVD only?
So Daraj, thanks for joining us. Nice to hear you joined us. The MRI we need, folks, is two things. We need the report, which you can do a picture, JPEG, but we also need the actual DICOM, D-I-C-O-M image set, which is around 300 pictures in a format your computer cannot look at. Maybe someday in the future, somebody will write a program. But the DICOM images are scalable, measurable, and manipulatable, and that's what I need. I need to be able to scroll through them side by side, look at them to kind of get a 3D picture of what's going on. So we need the DICOM images. You can send us your CD of those images. You can take the CD, put it in a computer, open the file, sweep the file onto our website or portal, which you're going to get to if you fill out the form on the free MRI review. That's what I would recommend you do. Start completing the form, get to the part where it says, how do you want to get us the images? Click on portal, web portal, and open your CD and copy and paste, or just drag and drop that file of DICOM images or the whole file on the CD, just drop it in, and then we'll get it. We need three things, folks. We need your history, what's going on, which you fill out on the form. We need your report of your MRI. We need the images of the MRI, which are DICOM. Do not send us JPEG images. They won't work. And then we can schedule you for your free MRI review with me. You'll get to meet me. I will figure out what's causing your pain. Literally within 2 minutes, I'll know. Thank you, Lily. And then I can tell you exactly how to fix it. That's how it works. And that's why people come from all over the world to Deuk Spine, because we can tell exactly what's wrong and how to fix it. I will say one thing as a disclaimer. If you're having pain on the MRI review, you're having pain right here, okay? And I ask you anywhere else and they say no. And then you get here and you're having pain here, but you're also having pain here. Well, that's a different source of pain. It's not coming from your disc. That's your piriformis or your SI joint. I will figure that out when you get here. But don't be surprised about, we should do a study on this, we will. What percentage of our patients that get here end up getting another diagnosis as to a secondary cause of pain, not the primary, secondary. Probably 20%, 25% do.
Next question comes from Roscoe on YouTube, once more, asking, on my first MRI 2 years ago, my annular tear was shown as a bright white dot. On my newer MRI, the dot is gone, but now it is a horizontal bright white line across the back of the disc. Bigger tear now?
Great question, Roscoe. Why was it a little white line, a little white thing before, now it's a longer tear? So to answer your question, I don't know exactly why. Nobody in the world can tell you exactly why. However, what I can tell you is the possibilities. And there are two possibilities. One is that at the time you got your first MRI, you had more inflammation. That's why you saw the bright spot. That's inflammation. That's what we've been talking about, inflammation of the tear. The second possibility, as you pointed out, is that the tear's gotten longer. They're both very good possibilities, and it could be that both of them have happened. In the end, there's one solution, and that is the surgery you just watched us do. Come here, get it done, get out of pain.
This next questions both come from Darren on Facebook. First question is, how many discs can you fix in an operation, and can the DLDR work on degenerative discs?
Darren, thanks for joining us. How many discs can I fix in an operation? Well, it depends on the part of your spine we're talking about. If it's the cervical spine, I can do 4. If it's the thoracic spine, I could do 4 from one side, unilateral, we call it unilateral, not bilateral. And in the lumbar spine, I could do 5 discs unilateral. And I could do a combination where I'm doing like 1 or 2 unilaterals, maybe a bilateral or 2. So it's very rare that we need to break up your surgery into 2 separate surgeries on 2 separate days for the same body part, like your lower back, for example. It's common to be able to get it all done in one surgery. There are several limiting factors, and I don't want to get into too much detail, but the best thing to do, to be honest with you, Darren, is fill out our free MRI review form, send us your MRI DICOM images, either sweep them in or send them by mail, FedEx, UPS, or give us your portal link for your MRI Diagnostic Center portal link, plus your login credentials. We'll go in there and pull those films. And then do your free MRI review. I will tell you exactly what's wrong and exactly what needs to be done for your disc. And I will tell you that, and I'll tell you if we need to do it in 1 surgery or 2. If I had to bet, I'd say 99% we can do it in 1 surgery. Unless you've got pinched nerves that are causing you symptoms on both sides of your lower back at 4 discs or 5 discs. In that case, it's going to be 2 surgeries.
Next one comes from Marcia on YouTube, asking,
And Marcia?
I have UPMC health plan and was about to see if they do the surgery. My pain management doctor told me to go to UPMC or Cleveland Clinic. I'm looking around Buffalo, New York now, but not having luck. I see that they're looking for advice.
Of course.
Yeah.
Her name again is?
Marcia.
Marcia. Very nice to meet you, Marcia. I'm Dr. Deuk Machen. Here's my advice to you, Marcia. You've got one spine, and there are tons of horror stories of people out there that go out and get surgeries done at Mayo, UPMC, Johns Hopkins, Yale, Cleveland Clinic. It doesn't matter where they go. There are bad outcomes, bad results. Either they continue to have horrible pain, or they have a complication from the surgery. The cage migrates, the cage fractures through the bone, the screws get loose, you get adjacent segment disease, you get an infection, you have a vascular injury, you have a nerve damage, you have a spinal fluid leak. The list of complications for bad back surgery go on. And I could tell you something, there is no center in the world that's immune to complications. There's one place where we have the lowest complication rate, and that is Deuk Spine Institute. We literally have the lowest complication rate for spine surgery, okay? So the first thing you should be thinking about, Marcia, is who can fix my problem? Who can get rid of my pain? And only about 1% of the places out there can actually get rid of pain. Then you want to know who's going to get rid of my pain the most, like who's going to get rid of all the pain and permanently. And that makes it less than 1 in 100, maybe 1 in 1,000. Then you want to know who's going to fix me without having a complication, without having anything major go on. And that's, again, most places you go, complications happen quite often, not Deuk Spine. Then you're going to want to say, well, who's going to fix me in the least invasive way possible, with the least amount of scar tissue, bleeding, and trauma to my body, where I can heal the fastest. That's the surgery you just watched, Deuk laser disc repair. And then you're going to want to know who's going to fix my back so that the results last the rest of my life. Again, Deuk laser disc repair, that's the only surgery. Everything else causes other problems that end up needing more treatment down the road. So the reason we do this particular surgery, it's not because I don't know how to do other spine surgery. I know how to do other spine surgery better than the Cleveland Clinic, better than any other place. Honestly, I do. And I actually have videos of it, and I've published papers. I'm considered one of the world's leaders in laminectomy, discectomy, fusions, whatever. Okay? I just don't do them because they're not good for the patient. This surgery, minimally invasive endoscopic laser debridement, is the best in the world with outcomes. That's why we do it. We do it because it has the best results. It's the safest. So, don't screw around with your spine. Life is short. It's worth it. Come down to Florida. There's a reason why people travel all over the world to come here to have their back and neck fixed. It's because we are the very best and the least invasive, and that's what you want for yourself.
Next question comes from Samir, once more on YouTube, asking, Doctor, what cervical spondylosis? Oh yeah, Doctor, what is cervical spondylosis, and can the DLDR fix it, right?
Yeah, Samir, so what is cervical spondylosis? Spondylosis is a term that means the disc between two bones is degenerating. It's collapsing, you get modic changes, you get arthritis. There is no fix for spondylosis. None. Nobody can fix spondylosis. Only God could reach down and touch your disc and make it go back to normal. Once you have damage to your disc, you will always have damage to your disc. Okay? The question you really need to ask, Samir, is what symptoms am I having? Am I having pain in my neck, going into my shoulders? Do I have symptoms in my hands? How do I get rid of those symptoms? How do I get rid of those symptoms safely, without a complication? How do I get rid of the symptoms permanently so I don't have to keep coming back? Safe, permanent. How do I do it so I recover fast, I can go back to life right away? There is one surgery in the world that gives you all of that. That is the Deuk laser disc repair, what we just did. And yes, it works for spondylosis. It will not get rid of your spondylosis. It will not repair your disc back to normal. Nothing will. But the Deuk laser disc repair eliminates your symptoms in a way that's permanent, safe, and fast recovery. And there's nothing better in the world.
This next question comes from, it's a long question, comes from Michael on Facebook, and says, hi Dr. Deuk, Happy New Year to you and your team.
Thank you, Michael. Happy New Year to you.
Firstly, I just want to thank you for your live streams. You have given me so much hope to cure my back pain without fusion and disc replacement, which is all I've been told that I can do for the last 15 years. Looking forward to doing an MRI with you. My question is, does the annulus tear heal? Oh, does the annulus heal closed after DLDR, or is the best we hope for scars together?
Michael. Thank you for your question. Phenomenal question. So I'm smiling because your question is quite interesting. Here's a disc, here's a tear, the red is the herniation. I come in with the laser and I clean all of this out, and you see the hole there, right? That hole is a hole in the annulus. That is the annular tear, minus the herniation, minus the inflammatory granulation tissue, minus the scar tissue for the most part. Okay? Will that seal? The answer is yes. Will it seal with, will the annulus heal itself? Yes. What you really want to know is, what is going to close that hole? The answer is collagen. Collagen. What is collagen? Well, the annulus is made from collagen. Another name for it is scar tissue. Scar tissue is collagen. So that's why I'm smiling. Because yes, the annulus will heal. Yes, it'll heal with what the annulus is already made of, which is collagen. But you know it is scar tissue. So here's the thing. If you cut your skin right here and it heals, you get a scar. That scar is collagen. Okay? The unique thing about the disc and the annulus is that the annulus heals with itself, which is collagen, which is scar tissue, anywhere else in the body. except it's not scar tissue when it's the annulus. Because scar tissue means it's something that normally isn't there. But with collagen in the annulus, that's what the annulus is made of, is collagen. Okay? Now, it turns out there's 18 different types of collagen, right? Collagen 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 18. We used to think there were only 1 or 2 types of collagen. Now we know better that there's lots of collagen. Collagen is a fibrillary protein, and it has a basic structure made from amino acids that we call collagen, you know. But there's slightly different versions. So, point is, the annulus heals with collagen, which is scar tissue, but it's also annulus. So, it heals naturally.
And then last but not least, we have a question from Darren once more on Facebook asking, are there back pains that can't be fixed?
Darren asks, are there back pain that can't be fixed? No. We are now able to fix all types of back pain at Deuk Spine Institute. You can't go to your local doctor, Dr. Shmoo Bum Bum, over in wherever they are, Los Angeles, and say, hey doc, fix my back pain, because they have no clue how to do that, right? You have to go somewhere where they know how to fix it. And right now, I swear, 2024, January, we are the only place in the world that knows how to fix all back pain. So I would recommend you get my Zoom, you meet with me, I will fix your back pain. And we do it all the time. Thanks for joining us. We got two more surgeries. The next patient is a Deuk laser disc repair, 2-level, L3-4, L4-5. He's from local. He's from Palm Bay. So he's just down the road, about 30 minutes south of us. And he's here to get it. He injured himself at work. I think so, yeah. So he's here, injured his back at work, has 2 herniated discs. We're going to do the same surgery, but on one side. The last patient is going to be the most interesting patient of the day. For those die-hard Deuk Spine fans, we're going to be treating a condition called piriformis syndrome. And for those of you who don't know, it is one of the most common causes of chronic back pain that can last for years. And so few doctors know how to diagnose this thing. But we do at Deuk Spine. It's easy. And you can even confirm the diagnosis with a shot in the muscle, piriformis muscle, which takes the pain away temporarily, and then you know you got in the right spot. But I already know this guy's got piriformis. We diagnosed him before. We gave him a shot. Shot wore off. He's back. He wants a permanent fix. We're going to do the Deuk piriformis release. The Deuk piriformis release, because I invented it, as many other things I've invented. What's different about what we do is that the piriformis muscle, the piriformis muscle runs from the tailbone, which is right here. It's not in this picture, but it runs from here to the top of the hip, right there. You guys see that?
Yep.
And it's a fan-shaped muscle. Most doctors who treat piriformis with a release, they cut your gluteus maximus, your butt cheek, they destroy that whole butt muscle, they find the piriformis underneath it, deep to it, and then they cut the piriformis muscle, right where the sciatic nerve is. We do something different. I invented a technique where we release the muscle right off the head of the trochanteric, the greater trochanter, right there. And I do it percutaneously with a 4mm incision. So there's no downtime. We're not cutting and destroying anything else. I use an X-ray machine to find that, and I use a Bovie to cut it right off. Literally takes 15 minutes. We're the first in the world to do it, and it's worked. We've done it 7 times now, 7 patients, and we've gotten 100% of that piriformis pain gone every single time. It's outpatient, it's a Band-Aid, and we're going to do this patient on both sides at the end of the day. So if you're interested, stick around. It'll probably be around 5:30, but it'll be worth it. We're also going to do the DPR on his facet joints.